Hello, welcome to this edition of Health First. Today we will hear from Dr. Eric Fillinger with Fillinger Foot Clinic about stepping up for foot health. Stay tuned.
So I'm excited to be here with you and to talk about reconstructive surgery of the foot. When I've done these talks before, we've talked a lot about foot care and diabetes and wounds, and we do all of that. But I've never talked about what I'm most passionate about, which is reconstructive surgery of the foot. And so you may not have any of the problems that we're going to look at, but maybe you know somebody who does, and I'd love to be able to help them out. Today's slides are going to be mostly pictures. Nobody likes to read words on the screen. Nobody likes to be read to. I'm just going to show you pictures and tell a story. And I hope you find that interesting, and it's something that gets me out of bed every morning. It challenges me, and I am very much so driven by purpose. I'm told by my family that I'm a very driven person and that most people don't live their lives like I do, and my wife would tell you that I'm very hard to live with, and I am. But I know as you look at this first slide, there's all that alphabet soup after my first name, and so what do all of those initials mean, and what's the purpose of them? Why do I list them after my name? Well, the first one there, DPM, stands for Doctor of Podiatric Medicine. Yes, I am a real doctor, but I did go to a different type of school than your family doctor did. Your family doctor has either an MD or a DO degree. And in that 4 years of medical school, they study the entire body, head to toe, not spending any prolonged period of time on any one area. They do that when they get to their residency, and they'll do their residency in that first year. It's called an internship, and that's where you get more focused. The difference between a DPM and an MD or DO is that I decided I wanted to work on the foot and ankle before I went to medical school. And so I knew that's what I was going to do. So when I did my anatomy class, I used the same exact textbooks as those that were at Case Western Reserve. I had the same professors. The difference was when we went to anatomy lab and studied the body, they spent 3 to 4 months from here up, and I spent 3 to 4 weeks from here up, and I spent 6 months from the hips down, and they spent 6 weeks from the hips down. So a little bit different focus there. I also did not study how to deliver babies. So if anybody goes into labor here today, sorry, I can't help you. That's out of my area of expertise. And then those last initials after my name, the FACFAS, stands for a Fellow of the American College of Foot and Ankle Surgeons. This is one that I'm most proud of. Those who are members of the American College of Foot and Ankle Surgeons, you can't just call them up and say, hey, I'd like to join that group. You have to first go through a very rigorous board certification process that involves a couple of different written tests that you take. Upon completion of your residency and doing a surgical residency. And then you have to take an oral exam where somebody grills you and gives you very difficult cases, and you have to tell them what you would do and why you would do that. And a lot of times there isn't a right or wrong answer. They just are evaluating your thought process. And upon completion of that, then there's an expectation to maintain a certain level of scholastic achievement, continuing medical education, and continuing research. And so when you see those initials after somebody's name, you can be assured that they have been rigorously, boy, easy for me to say. They've gone through rigorous training in foot and ankle surgery training, and they know what they're doing. So what made me decide to specialize in feet? Amy touched on that a little bit when she did my bio. Still am, an avid runner when I was in college. have competed all over the world. Running took me a lot of places, and that's part of the reason one of my special interests is in treating the runner, and I treat a lot of runners throughout North Alabama. But I injured my foot in my senior year. Amazing the way God works. He used that to direct me where He wanted me to go. And through that process, I really was drawn to the foot, number one, because it's a very complex structure, a lot of physics involved in the foot, and yet also very varied in what I see day in and day out. I like my schedule. I have a schedule. I have a life outside of my practice. There are some specialties that, if your appendix is about to burst, you don't want to wait until the morning. You want somebody to take that out right now. And there's not very much in the foot that is that way. There are some things, but not very much. And so it affords me a nice family life. And I see a wide variety of things. I treat skin diseases. I treat bone conditions. I treat neurologic conditions. I treat vascular conditions, muscular conditions. I treat them all. If it's in your foot and ankle, I treat it. And we're going to talk about some of those things today. But it was that injury in college that kind of pushed me towards the foot. Amy read our purpose statement. I told you I'm very purpose-driven. Emily and Cindy will tell you that we talk about this quite often because it's very easy to get off track. And one of the things that concerns me as a physician with all the changes that you're seeing in medicine, and change is not necessarily bad, but one of the things that concerns me is doctors, it's becoming increasingly difficult to care. We treat. We don't care anymore. I didn't mean that the way it sounded. We do care, but it's very difficult to care for people. It's become you come into the office and what's your problem? And we treat that problem and you leave. But you remember this, as I look out, this generation, you remember your family doctor being a part of your family. He knew, in a lot of times, he delivered your children. He took care of every problem that you had. And he knew your other family members. And he was intimately involved with your family. And we come fast forward to 2014, where we specialize very specifically. And so we do treat very specific problems, which is good because our knowledge base has grown about certain conditions. And so in order for us to maintain an expertise on something, the only way you can do that is to focus and drill down and be very specialized. But you know what? Your foot's still attached to you, and there are issues surrounding you that make your treatment plan very unique to you. The way I treat one person's problem may be very different from the way I treat the same problem in another patient, just simply because of their circumstances. If you're caring for a loved one that can't get up and walk, and you have to be their feet, and I'm proposing to do something that's going to take you off your feet for 2 months, you're like, I can't do that. And you're right. And that goes back to caring and being diligent and compassionate and have integrity as we do that. That's the thing that amazes me about the great physician, Jesus Christ. He never once turned anybody away. He and the disciples would go off to be by themselves, and people would still find him. He never turned them away. That's amazing. That is my purpose. I don't always hit that, and we're still working on that. Where are we headed? I want to be the premier provider of medical and surgical treatments of the foot and ankle in all of North Alabama. And slowly but surely we are hitting that, and we are doing that. But that's what gets me out of bed and drives me every morning. So I've broken down the foot. There's 3 different regions. We're going to talk about the forefoot, the midfoot, the rear foot. And I want you to remember this first picture because we're not going to talk too much about this picture, but it tells a story about where we used to be. How many of you have ever seen somebody after foot surgery with these little pins sticking out of the foot? And you're like, ooh. Okay, I'll get you off this screen because you are eating, but just remember that. On this screen, people are surprised when I start talking to them about a big toe joint replacement, because everybody's heard of having their knee replaced and their hip replaced and their shoulder replaced. But one of the joints that gets banged up the most in our body is our big toe joint. Our big toe, all of our body weight is supposed to go through that area that's about the size of a nickel. And so you can imagine there's a lot of wear and tear on that joint. And sometimes, as you'll see as we go along, sometimes we fuse that joint because you can function very well with the fusion. But especially some of my younger patients, and I have a birthday coming up here in about a week, and I'm going to turn 46, and so 60 is younger and younger. But in some of my younger patients, they really still need to have that motion of the big toe joint. There's things they still need to do, and so this becomes a very good option. And so if somebody ever says to you, I think I need to have my big toe joint replaced, you can tell them, yes, you can do that, and it works very well. That little implant that you see there, I have another view of it. It's looking up from the top. It's like a little button with a little stem that sticks out into that bone in the big toe there. And before this patient's surgery, they could only move their big toe about 10 degrees, which is really not a whole lot. And now they can move at 60 degrees, which is normal. We don't always get that much motion when we do that joint replacement, but the motion that is there is no longer hurts and is much better than what it used to be. This implant was designed by a couple of doctors that were actually in the Detroit, Michigan area where I trained, and they developed this implant probably about 35, 40 years ago. And there's implants out there that have been in 25, 30 years. Most people don't live beyond that point. So these are much more durable even than your total knees and total hips. Those life expectancy is about 10 to 15 years on those. But these do quite well. This is one of those cases where this patient really needed to have their big toe joint fused, because when you look at that joint, and I want you to look at that second toe. Look at that second toe very carefully. I kind of helped you out because there's a line going down the middle of the bone going to the second toe. And it's shifted towards the big toe, isn't it? And that's what we call pre-dislocation. The toe's not dislocated yet, but if we waited a few years, it would be. And it becomes very, very painful. What's happening is her big toe is pushing that second toe out of the way. It's pushing it up and over. And eventually what happens is the second toe does that on the big toe, like cross fingers. And very difficult to wear shoes, very difficult to walk, creates a lot of pain in the ball of the foot. So how did we fix that? Well, we fused that big toe, and we shortened the second toe a little bit. And this is what I want you to notice. Remember that pin I was telling you about? About 2-3 months ago, I quit using pins. Now, there are sometimes we have to use them, but I didn't like, as a surgeon, I never liked those sticking out either. Now, you're going to have to look very closely to see this, but I want to point out some new technology that's come. My pointer is pointing, you can kind of see just this lighter area right here. That is actually a little bone graft that has been dulled down to a little rod that we can stick in there, and it will help that hammer toe surgery heal. You can see that rod right there in the middle of that toe, and that helps that bone knit together, okay? The other very interesting thing about this x-ray is some of the new technology that's in this plate right here. It used to be that we would just put some of those wires across that joint, but the problem with a wire is that's like a nail for all of you who like to do woodworking in here. When you take a nail and you nail two pieces of wood together, it's very easy to pull those apart. And those boards will spin on each other as well. And so if you want to squeeze two pieces of wood together very tightly so that they don't move, you use a screw, right? So technology advanced from a pin to a screw. The Swiss developed those screws. But then we started using plates because plates shielded stress. But the problem with the plates were they were very thick, and you would feel those. You may know somebody that broke their ankle that has a plate, and you can count the screws, you can see it. They're real thick and real bulky. But now they've developed newer materials, and now the screws actually screw into that plate. It's what we call a locking plate. And with this technology, this patient was up walking on their foot 3-4 days after surgery. The first few days they couldn't put any weight on their foot, but then afterwards they were fully weight bearing on that. Now when I say to somebody, you need to have this done, and they say, but I have to take care of my husband who is very ill, now this becomes a much more reasonable option for them when they say, okay, I only have to find somebody to help me for a week. I can do that. So just some advances in technology there that I wanted to point out to you. One of the other things that we specialize here, you can see that this patient previously had surgery as evidenced by the two screws. Helps if I point it the right direction. The two screws that are right there. And part of the problem was this patient has a very complex deformity. What we call the metatarsals. That's the bones here in the middle of the foot. You can see it almost looks like the wind is blowing them this way, and they're not supposed to do that. And so this patient was looking at having either major reconstructive surgery, or her primary complaint was here, and you can see the second and the third toes aren't on the bone like they're supposed to be anymore. And so we did a very similar procedure with them. However, this was one of the first times I used one of those little rods, and their outcome was great, but that rod was too small. And so that's why we call it a practice. We sometimes learn from our hindsight is 20/20, right? But she's doing very well and walking now and not having pain and doing quite well. So just wanted to point out some of those newer things that are coming. So maybe as time progresses here, you'll see less and less of those wires sticking out of people's feet. Midfoot surgery. When we talk about the midfoot, we're talking about this area that's been shaded red. So you have the forefoot here, and that's what we call the metatarsals and the toes. And then you have the midfoot. And think of the midfoot like your wrist. On the back of your wrist here, you have a whole bunch of little bones right there that work together. And that's the same here. You might look at this x-ray at first and say, I don't see a problem. But actually look at this bone right here. It's like a little rectangle. And this bone right here is supposed to sit right on that one right there. So this patient was involved in an accident. This happens a lot when you're in a car accident and you slam on the brakes. That force from the brake pushing back, it pops the foot out of place. And it gets missed a lot. You go to the ER, they look at that, and you look at that bone and you say, well, it's not broken, but actually it is. If we were to get something like an MRI or a CT, you'd see that these two bones right here are actually in a whole bunch of little pieces. And that foot is not stable. And if it goes untreated, in about 5 or 10 years, there will be excruciating pain that will prevent them from walking. So what we do is we put a whole bunch of hardware in that area. And yes, it is a little bit difficult to get that many screws in that little area. Those of you who work with wood can attest to that. But that is very, very strong and holds all that together, and then that bone heals. And most of the time those screws stay, but some of the time we take those out. It just depends on how good a shape the cartilage is in. If the cartilage is very damaged, then we go ahead at the time of surgery and take that cartilage off and just do what we call a primary fusion so that it doesn't give you trouble down the road. But if the cartilage is still in pretty good shape, then we go back in and we take out those screws. This is the little system that we use to get those screws in, and so that we're not banging into each other. Technology is great. And this is just a little animation showing how those screws go in, and sometimes we put a plate on the top too there, depending on how unstable that joint is. So I mentioned that, and that actually is a form of what we call a fracture dislocation. And I want to start here on your left and work right and tell me what you think we need to do for these fractures. You guys get to play doctor, okay? I think everybody can see those broken bones right there. What do you think we have to do to those? Put screws in them. Yeah, put a plate on it. Why? Well, for a couple of different reasons. That bone has shortened a lot. And so when you walk, keep in mind that this part right here is the ball of your foot, okay? And it's a little arc that it should create. And when those bones shorten, they don't bear weight like they're supposed to, which means that this one right here and this one right here are going to get overloaded. And about 2 or 3 years down the road, you'll have a really painful callus that you won't be able to stand. And you'll be coming into my office saying, "Can you shave this callus off the bottom of my foot?" And I'm like, "Yeah, I can, but it's going to come back." "We'll cut it out." "Well, but it'll come back." You have to restore that normal anatomy. Okay, God made us the way He did for a reason, and so when something like this happens, yeah, you got to pull them back out to length and get the two ends touching each other again. What about on this one? You can see the break right there. What do you think we need to do with that one? Just put their shoe on, put them in a cast, or put a screw in it? You're right. You're right. You do want to put I guess we're talking about surgery, so you'd think that. But the reason why is because that one is shortened, and when it's at an angle like that, it's not stable. It'll keep moving. And when it moves, it probably won't heal. And so we want to pull that back out to length, put it in the right plane top to bottom, and stabilize it. And the best way to do that would be with screws and plates. Now, this one is the toughest one. And with the light, I don't know if you can see it, but that little toe is broken. So who says it's a little toe, you can't do anything about it? Who says that? Okay. Who says I need to put a screw in it? I got a couple. Good. No, we're not going to put a screw in that one. But it does get treated. If you broke your little finger, would you want it treated? Yeah. And your little toe does serve a purpose. Okay, otherwise we'd just take it off when you were 2 or 3 years old. Okay, it does serve a purpose, and it does need to be treated. It's pretty easy to treat. It needs to be immobilized, just like any broken bone does. And taping does not immobilize. So we don't just tape the 4th toe to the 5th toe. Okay? Yes, ma'am.
You would surround it with something for extra support.
Yes, we put you in a special shoe that keeps that toe from moving, and it takes about 4 weeks, and it's healed up enough to where you can get back into your regular shoe. Okay? So very good. You guys can get your degrees as you head out. What about this one?
Cracked.
It's cracked, isn't it? Right here. So how do you think we would treat this one? How many of you remember Julio Jones? Yeah, really good wide receiver. Okay. Do you remember when he left school and he entered the draft? They found a fracture in his foot, and they wouldn't let him sign his contract until he had surgery and was cleared from the surgeon. Do you remember that? Okay. Julio Jones had what's called a Jones fracture. It was not named after him. Dr. Jones named it hundreds of years ago. Okay, but it's a very specific fracture, and this is the 5th metatarsal. And the problem is this area right here, from here to here, has a very poor blood supply. Very poor. And about 75 to 80% of the time, these will not heal. With immobilization and non-weight bearing, they will not heal. They will not, because the blood supply is so bad. So the way we treat that is we put one big old screw right down that bone. And that is why I'm board certified. That will make you lose your religion because that bone is not straight, and you're taking a straight screw and you've got to get it perfectly down the middle of that bone. But you can still see a little bit of the fracture right there, and that'll fill in with time. But that one has got to be fixed. Otherwise, it'll just chronically be painful. This is somebody that had another fracture there as well, just showing an example of that. Now we're moving back to the rear foot. How many of you have heard the term fallen arches? I got fallen arches. Yeah. And this is what people are talking about when they say, I have fallen arches. So does your arch really fall? Well, it does, but the reason it does is because there's a tendon that comes down the back of the leg here and attaches right on the arch. There's one in the back and one in the front. And that one in the back will get torn. Some professions have done a better job than others at educating patients and getting them to be able to visualize what's going on in their body. And one of those areas is the shoulder. How many of you know what a rotator cuff is? Yeah. If you can't raise your hand, it's probably because you've done damage to your rotator cuff. Well, think of this condition like the rotator cuff of your ankle, okay? That tendon is what holds that arch up. And when that tendon gets diseased, that arch collapses. So this picture over here gives you a good idea of what a tendon looks like if we were to take a tendon out of one of your bodies and look at it underneath a microscope. You know how a rope is actually a whole bunch of little strands that are twisted together? And then those twisted strands are twisted together, and then those twisted ones are twisted together depending on how big the rope is, and that gives a lot of strength. Well, that's the way our tendons are. There's these little individual fibers that get grouped together, and then there's a covering around those, and a whole bunch of those come together, and there's a bigger covering around those, and that's what makes your tendon. But it'll get inflamed and frayed like that, and the inside of that tendon will tear. So this is a surgery picture here showing that tendon that's torn and it's very diseased. Right behind it here, this is the tendon that goes to the little toes, okay? This tendon should look about the same as this one. It should be a little bit bigger, but it's very swollen. There's a tear in it where they've got it grabbed with the forceps. There's a tear in that. And how do we treat that? Well, initially, we immobilize. That's the nice thing about an MRI. That's why a doctor would say to you, well, I think you need an MRI, is because a tendon doesn't show up on an X-ray, but it does show up on an MRI, and we can see those tears on the MRI. And so depending on the size of it, we grade them from 1 to 3. And if it's a grade 1 tear, we can put you in a cast, and most of the time that tendon heals up. But if it doesn't, it has to be repaired. Otherwise, that arch is going to collapse. So this is a picture of a patient who actually had a very bad tear, had an ankle injury, had it treated, wouldn't get better, and this is a couple of years have gone by. And I want you to notice a couple of subtle things here. Number one, as we look at this, is the bone that sits on the top of your foot and goes, your leg's up here. See how it's pointing down into the floor? It should point down towards the big toe. But that tendon attaches right about where I drew that circle. Okay? And it acts like a sling and it holds that bone up. And it's not doing it anymore. That bone is sagging. But you can also, when you look at this joint right here, you see this line right here, but then you see how it opens up into a triangle? It's what we call a breach. That midfoot is collapsing. It's no longer together. That arch has fallen. Okay? And that becomes very, very painful. And if left untreated, this joint right here, this joint right here, and this joint right here become very, very arthritic, and you can't walk. And there is no joint replacement for that one, and we have to go in and fuse it if you're surgically able to do that. That's a very big surgery. This is a bigger surgery than having a knee replaced. So you have to be at a certain health level to do that. And the challenge with that is it's been going on for years, and so most people have become more and more sedentary, and you know what happens when we become sedentary. Our heart doesn't do too well, our lungs don't do too well, and so these patients aren't real good surgical candidates. So what we want to do is catch it at this point, not when they're bedridden. Okay, it's too late then. This is looking at the foot from the top, and it's not real clear, it's a little fuzzy, but I've drawn an angle right here. One of the things that happens when that arch collapses is you get what we call the too many toes sign. If we look at you from the back, we can see your toes peeking out from the side of your ankle there. They shouldn't do that, they should point forward. And that's what's happening to this patient here. And you can see the back of the foot has swung this way, and the front of the foot has swung that way. One of the advances that we found, and this isn't really a real good picture because we don't really put it this far down on the bottom of the foot. It actually goes up here behind the ankle. But this is a tendon graft that we put on, and it's actually skin. You're like, what? You can take skin and stuff it inside my body and it works? Yeah, skin's amazing. It will become whatever you lay it on. And so we take it and we lay it around that tendon. Once we clean that tendon up and sewn it, it's usually really, really small. That tendon is normally about the size of my index finger. And when we're done cleaning it up, it's about the size of a pencil. And so what we do to get it back to that normal girth is we put this graft around it, and it helps that tendon heal faster. I did have an occasion one time, I had a patient that we did this on, and she had just been taken out of her cast, and she was just starting to walk. Obviously not real strong yet, and she was putting her pajamas on at night and got her foot caught in her pant leg and tripped and fell, and she tore her tendon again. And so we had to go back in, but she didn't tear it in the same spot. But I had the opportunity to see that graft after we've put it in there, because I don't have too many people that volunteer to have themselves open back up again just so that I can look at it. But I did get to see hers. And it was very interesting because I sent a section, the tear was right above the graft, and so there was a portion of the graft that got sent to the pathologist to have him look at it. And he called me up and goes, "What am I looking at here? I see this tendon, but then every once in a while I see a skin cell." I was like, yeah, no, it's... and I explained to him what happens, but that graft, it becomes tendon given enough time. Pretty neat invention. So this is that same person. You remember her front of her foot was swung over, and the back of the foot was going this way, front of the foot going this way. And this is after we fixed it. Everything's nice and straight now. As you look at that, we use that second metatarsal as a reference. It's going right up the middle of the leg now. And what we did was we put a couple of different bone grafts in there that are kind of like a piece of pie. I highlighted it here with the blue lines, and that's what that plate is doing, is holding that bone graft in. And this is a few weeks after surgery, and so that graft is incorporated pretty well. And it's pretty hard to tell the difference between her native bone and that bone graft. This was where we repaired that tendon. We tightened it up so that now, as you look at the side, Remember that triangle you saw right here? That's gone. Everything is lined up like it's supposed to be. Okay? Pretty amazing, isn't it? I love my job. I love finishing up with the surgery and looking at somebody that had a flipper for a foot and now has a foot. That's exciting. And this one is probably the one that makes me the most excited. Can anybody see the problem with this foot? The problem is this person has no feeling in their foot. And they have a fracture that they don't know about because their foot never hurts. And they keep walking on it. And eventually what happens is the bones start to work out through the bottom of the foot. Yeah. But they still don't say ouch. The reason they come to the doctor is because their foot looks like a football and it's red and hot and swollen. Guess what they get diagnosed with most of the time? Nope. Nope. Gout. Because what makes your foot turn red, hot, and swollen? Gout does. But gouts usually appear in the big toe. Yeah, you can get it in the ankle. But it usually doesn't make your foot look like a football. Makes it swell real big, but doesn't make it look like a football. Yes, yes. This is a condition that's called Charcot. Charcot neuroarthropathy. In order for this to happen, you have to have lost the feeling in your foot. Now, the vast majority of people that happens to are diabetics, but you don't have to be diabetic to get this. It was originally described in people with a condition called tabes dorsalis, which we really don't see very much of because that's associated with syphilis. But now we see it with diabetes. Leprosy was another one that we used to see it with, but you don't really see much leprosy anymore. So remember that picture we looked at a long time ago where I put all those screws in that one little space and I showed you where the bone was broken? I don't think any of you need to go to medical school to see where this one's broken, do you? I mean, you can see that these bones right here are not lined up at all. You're kind of like, well, what happened to all those bones that are right there? It just looks like a bomb went off in their foot, and that's exactly what happened. And you can see down here where that bone is starting to come out through the bottom of the foot. This white area right here, that's actually a plate that they're standing on. This is a standing x-ray. And that bone is trying to work its way out through the foot. And they developed a sore there. And you can see the metatarsals are actually sitting up on top of the rear foot. And notice the position of that bone we call the talus. See how it's pointing down into the floor? But also notice that the heel bone is pointing down into the floor. The cause of this is a really tight Achilles tendon. And so in order to fix this, we do have to lengthen that Achilles tendon. And then we can get these bones back up where they're supposed to be. This is the after. And this is what I'm so excited about. Again, she's standing. She has a normal arch again, doesn't she? Now, this condition, without this procedure, if this had not been done, the chances are very high that she would lose her leg because that foot shape is not compatible with walking. It is nearly impossible to keep a sore off the bottom of the foot. I've had a few patients that have done it, but the vast majority end up losing their leg. But if we catch it when this happens, then we can do the reconstruction and fix it. And it takes a lot of patience on the part of the patient to be willing. This happened in December, right before Christmas. And I took this x-ray of her yesterday, right, Emily? Yeah. And she cried when she was finally able to stand and walk on her foot. because it had been 5 months that she had been off of her foot. But her surgery was very successful because she did what she was supposed to. So she was one, I said, okay, we can do this, but this is what it's going to take. And she and her husband said, we can do this. And I said, I'm going to warn you, you'll get tired of it. After 4 weeks, you'll be like, okay, Dr. Fillinger, I'm done. And once we start, we got to finish. But, I'm proud of her because she listened and she did what she was supposed to. She took very good care of her foot, and now she has a normal foot again. Okay? And that gets me out of bed in the morning. You remember what the picture looked like. Let me go back. You go from that to this. That's a normal looking foot again. You're like, oh, okay, there's all her bones. And yeah, that's a lot of hardware. But it keeps her walking. So any questions?
We hope you enjoyed this episode of Health First. If you would like more information on this episode or any of our other episodes of Health First, please feel free to contact us at 256-737-2600 or on our website at cmchospital.com.